Good evening, everybody. Seems like a lifetime since we last spoke. So today we're going to be chatting about testosterone, the highs and lows of testosterone. Now, we've had some requests, a few case studies that were sent to us, but mainly dealing with testosterone in females. Let me just say from the onset, this is a talk mainly concentrating on testosterone use in males, and we can do testosterone in females in a future webinar. So these are my disclosures. Let's start by looking at testosterone, what it is, its metabolized, and its targets. So testosterone's an androgen, it's a sex steroid, it's a hormone, and basically can break down into quite a few metabolites. And its effect is multiple. So whilst most people associate testosterone just with sexuality, and yes, you can see it has an effect on the sex organs, but it also influences voice. That's why men tend to have deeper voices. Its influence on muscle is obvious. Its effect on bone is important. Cognitive function in terms of what's happening from a cholesterol perspective, liver, and then we mustn't forget that it can aromatize to estrogen, which in itself can have an effect on quite a few organ systems. And then testosterone can become dihydrotestosterone, which has mainly androgenic effects in terms of its influences on hair and then the sex organs. So testosterone can be converted to dihydrotestosterone under the influence of this enzyme 5-alpha reductase, and testosterone can be aromatized through estradiol to estrogen as well. Now, the performance of these enzymes will vary from person to person, and basically it's genetically determined. So you'll see there's a percentage of men that will get bald, and if testosterone and DHA cause baldness, then every male would be bald and pimply by 18, but we're not. Which obviously means some men do convert testosterone to dihydrotestosterone and androstenedione down more than others because of this overactive enzyme. And then with this hormone's influence on some of the receptors in the scalp, you tend to lose hair. And so all men will convert, not all, 99.9% of people will convert testosterone to estradiol because of the presence of aromatase, and that estradiol is very important. And we used to think that estrogen in men was only important from a point of view of its influence on bone metabolism, but now there's been work showing its influence on fertility in terms of sperm, and then, of course, in terms of cognitive function as well. So I gave a talk last December to the Fertility Society. It was an online talk, and I had quite a few slides on the influence of estradiol on male sperm. So if we look at the effects of testosterone, we mustn't forget that testosterone has an impact in utero to influence what's happening with the sex organs. Prepubertally, it's important from a point of view of phallic size, testicular growth. Too little testosterone, too much estrogen, the ratio that will then affect gynecomastia, the way your body is shaped, and so forth. But today we're going to be talking mainly about testosterone in adulthood, and we know that a low testosterone can have a multitude of signs and symptoms, and we're going to try and go through it. So, like our female counterparts have a life cycle in terms of what happens to estrogen, this is a little funny cartoon in terms of showing what happens to testosterone from youth to progression in terms of life. So testosterone deficiency syndrome is real. It has a definition, and it affects the function of multiple organ systems and has a significant loss in terms of quality of life. The definition is a clinical and biochemical syndrome associated with advancing age, characterized by typical symptoms and deficiency in serum testosterone levels. Now, before we go anywhere, hey, this didn't project too well. Basically, this is just looking and saying this is normal testosterone represented here in terms of blue. And then men become symptomatic once we've had a 50% reduction in terms of testosterone. Now, one needs to appreciate that if you put 3 men in the room at age 18, the testosterone levels are going to be different. So it's quite a wide range. So, for instance, if we've got a male Y who initially had testosterone levels of around 27, you have a 50% reduction in that. That patient's going to become symptomatic at around levels of 13, and yet that would fall within the normal range, as opposed to a male who started off at, let's say, 18, will become symptomatic a bit later. So modern medicine's not yet dealing with that issue. We used to just having certain reference ranges, and anything pliable or has to be personalized becomes a bit more difficult to apply, because it's difficult to do studies on a moving target that varies from a person to person. So we'll touch on reference points in a bit, but there are key symptoms that were attributed by physicians to testosterone deficiency, and these physicians were unprompted. So this was a massive study done in Europe, and it was a questionnaire sent off to general practitioners, physicians, urologists that were dealing with men. And they said, well, when you have a guy with low testosterone, what's the commonest symptoms? And this is what was reported. So 71% said they'll present with a low libido and low sexual desire. 51% of them will have erectile dysfunction. About 40% will have fatigue, loss of power. It affects mood. The obvious is loss of lean body mass, and then in some, loss of bodily hair. Now, not scalp hair, but basically hair on the chest or in the axilla or in the pubital area, or they may even report a decrease in the rate at which their beards grow. So, in terms of testosterone deficiency, once you start getting levels below 15, and there's a big study. Zisman has done extensive work in the field of testosterone deficiency. This is a publication that goes way back, I mean, like close on to 30 years. And we were fortunate enough to have audience with Zisman at an endocrine and a urology meeting in South Africa about 10 years ago. But his work showed that once you get a level below 15, you get loss of libido and loss of vigor. Once it starts going below 12, you start getting obesity. So the low testosterone is contributing towards obesity. But I'll just show you later that it's an incestuous circle, that one. Once it goes below 10, low testosterone directly affects mood in terms of being the cause of depression. It affects sleep architecture, loss of concentration, and actually is a risk factor for type 2 diabetes. And only once it's below 8 do we get the commonly quoted symptoms in Harrison's in terms of erectile dysfunction and sometimes hot flushes. So you can see denoted by the double stars the p-value in terms of the study, and you can see that testosterone goes beyond sexuality. So what are some of the conditions with low prevalence of testosterone? So who of your clients are likely to be affected? So obviously, and not many of you can see these patients, it's mainly limited to neurologists, neurosurgeons, and endocrinologists, but clients who have a cellular mass. So a mass around the pituitary area, or had radiation to this area for whatever reason, or any other disease in the pituitary hypothalamic region, that's going to start affecting the production of GnRH, FSH, LH, which then has a downstream effect in terms of low testosterone. There are certain treatments that will affect testosterone production, like steroids, the antifungals, and certainly opioids have been shown to suppress or have depressed levels of testosterone. HIV-associated weight loss, in fact, that's why a long time ago, the treatment for improving muscle mass in patients with advanced HIV was either growth hormone or testosterone or both. End-stage renal failure will have the vast majority of these patients will be deficient in testosterone. More moderate to severe chronic obstructive lung disease, clients who present with infertility, osteoporosis in young men, and then about 50% of men with type 2 diabetes will have testosterone deficiency. About 3% of type 1s will have testosterone deficiency. So this is not by any means an exhaustive list, but this is what you commonly see in practice. So what is normal? So let's get to the reference range. So about a decade ago, at a big meeting that had people invited from all over the world to come to consensus in terms of what was considered normal. So when we look at total testosterone, this is what's produced by your clients. Normal is 12 to 27. Now, testosterone gets bound to something called sex hormone binding globulin. This is the transport system. And then basically, testosterone will get delivered to the tissue where it has its action. And most laboratories will give you a calculated free testosterone index. So it's a calculated one. It's not actually, it's too expensive to measure the actual free testosterone. Can be done, mainly reserved for research, but this is a good enough surrogate marker. So you need to be okay with all three of those. The gold standard in terms of measuring total testosterone is using liquid chromatography tandem mass spectrometry. And this free testosterone, which is measured by another system, equilibrium dialysis, is the best. However, it's very expensive. So the transport molecule, because of course it's important, there's a difference between what's produced and what's delivered. So there are some conditions that are going to affect the transport molecule. And this talk is going to be available on the webinar, so you're always able to go and look at it and download this. But there's quite a few things that are going to increase sex hormone binding globulin. In other words, it's going to hold on to the testosterone and not free it up. And that's function of aging, thyrotoxicosis, acromegaly, smoking, liver cirrhosis, anticonvulsants, and HIV. And there's some that will decrease sex hormone binding globulin. And there's a whole list out here, but including some endocrinopathies, metabolic syndrome, obesity, type 2 diabetes, and you'll see statins play a role here as well. So one needs to appreciate that, like any other hormone, testosterone has a circadian rhythm. And then within this, you'll have fluctuations throughout the day. So testosterone has a pulsatile nature to it and a circadian rhythm. And so what happens is we have peak levels after 4 a.m. in the morning. But by about 10 o'clock, we start seeing reductions in testosterone. So typically, if you ask an 18-year-old, do you get early morning erection? And it's like clockwork. Between 4 and 6 o'clock, majority of the males will have an early morning greeting. And so that's because all the counter-regulatory hormones kickstart around 4. a.m. So one of the first signs in a young person indicating that there might be issues with testosterone in terms of production or circadian rhythm would be the loss of early morning erection. However, as one gets older, we start losing this circadian rhythm. So how are we going to be measuring testosterone? So we need to decide which tool we're going to be using. So world over, people have decided to use total testosterone. And so I think if we all stick with the same tool, we're all likely to try and achieve similar results. And of course, it helps if everybody uses it as a study tool. And so total testosterone is widely used. We say, do your test early in the morning. I do mine fasting between 8 and 10, so it gets standardized. Total testosterone has to be confirmed at least on 2 separate occasions. And total testosterone is an excellent predictor of hypogonadism. So it is only in borderline cases where the free testosterone or the bioavailable testosterone at the tissue level becomes important. So typically, this is what a blood test would look like. So this particular client had a level of 8.2, which is obviously low. Normal is 12 to 27. Sex hormone binding globulin here, it's low. And you'll see in nature, unless this is the cause, whenever there is not enough hormone available, the transport molecule will go down to allow a higher free testosterone level. So in this particular patient, we had to make sure that it's not a pituitary problem. Prolactin was fine. You're going to see why I'm going to go through it. Thyroid was fine because thyroid and prolactin are treatable causes of a low testosterone. Cortisol becomes an important marker of what's happening with the rest of the adrenal gland, and ferritin is important because remember, for those of you who remember something from medical school, if you've got hemochromatosis or any other condition that allows you to accumulate too much iron, iron gets stored in the pituitary amongst other glands like thyroid and heart and liver and pancreas and testes. So here you have a double whammy. When the ferritin levels are high, you're going to get it deposited in the testes and in the pituitary, and that's going to have a negative effect. But typically, that's what a blood profile is going to look like. And it's important to try and distinguish what the cause is. So you can have primary hypogonadism, and this is failure of the organ that makes the hormone, in this case, testosterone. So like you can get primary ovarian failure or primary thyroid failure or adrenal failure. Here, the testes are failing, which means the end product is not being produced. But you can also have secondary hypogonadism, which comes from pathology higher up. This is where either the hypothalamus or pituitary is dysfunctional, so it is not making the hormones called GnRH, gonadotropin releasing hormone, which is made in the hypothalamus, and that normally tells the pituitary to make a hormone called FSH, follicular stimulating hormone, and LH, luteinizing hormone, and those two then work downstream to produce testosterone and LH. There are some very rare conditions, mainly ending up at endocrine practices. So androgen receptor defects, you can have 5-alpha reductase deficiency and aromatase deficiency. That's why I said almost 99.99% of patients will all have estradiol, but there are some people who don't have estradiol, and they very interesting for endocrinologists. But by and large, that's what you're going to be seeing. So I'm not going to go through it through this late. We got so many slides to go through. So out of the 180 odd slides I had for this talk, we chose about 80. But this is going to be available to you. You can Google it as well. There's an algorithm in terms of how you can test for testosterone and your workup in terms of cause. You can see that this is an international paper because of the way they measure testosterone, but by and large, you're looking at LH, FSH, trying to work out whether it's primary, secondary, and I'm going to touch on that. So here we go. So once you've established on 2 separate visits, measuring your testosterone levels early in the morning, hopefully fasting, and your levels are below 12, now you've established that the testosterone is low. So we need to figure out where the problem is. So you do an LH. If the LH is high, so let me give you another example that you see on a day-to-day basis. If your thyroid T4 levels are low, you will look at TSH. If TSH is high, it tells you the problems with the thyroid gland. So same thing here. If testosterone is low and if the LH is high, the pituitary gland is trying to get the testes to produce more testosterone and it's failing. And so here, a high LH indicates testicular damage. So here's an example. So somebody who's got primary hypogonadism, like Klinefelter's, or testicular damage, either from a tumor or trauma, torsion, any disturbances in testosterone synthesis, this is very rare, inactivation of the LH receptor. These are all testicular causes of a low testosterone. Bit of drama, so that guy is definitely going to have a problem, and that's an example of a traumatic injury. If you have low testosterone and the LH is low, not measurable, that's indicating the pituitary gland and the hypothalamic gland, either one of them did not respond to the low testosterone. They were supposed to have responded by going up, like here. So if they didn't, that means the problem is over here, because we're not getting stimulus from the higher organs. And here is an example, MRI, you're dealing with a tumor in the pituitary hypothalamic area, and that means obviously you're not making the hormones that are going to stimulate the testes to do their work. But by and large, the commonest cause is, or commonest presentation you're going to see is a low testosterone, and the LH is neither high nor low. And this has now been named testosterone deficiency syndrome. And it's mainly associated in metabolic syndrome. And so I'm not going to go through a definition of metabolic syndrome, but basically it's central obesity, measured in waist, in terms of waist circumference, and some of the other metabolic parameters, either abnormalities in LDL, triglycerides, blood pressure, or glucose. But I mentioned earlier is one of the commonest causes is type 2 diabetes, and this work was done by Paresh Dendona, and he visited South Africa, I think, in the late 90s. He's done some fantastic work. He's from Buffalo, and this was one of the first studies way back then showing that testosterone deficiency is more common than we thought. So they looked at over 300 men, average age 58, and looked at testosterone levels and found that over 50%, no, about 50% had levels below 12, and about 16 had a level below 7.5. So it's quite prevalent. So what's the putative cause? So before we go there, let's try and differentiate between the types of fat. So this is a cross-sectional view of an MRI, the abdomen. Here you can see nicely visceral fat, and this is omental visceral fat lying around the organs, metabolically very bad to have. So what they find in this testosterone deficiency syndrome is that when we have an increase in visceral fat, you're going to have an increase in aromatization of testosterone to estrogen. The high estrogen is going to then downregulate GnRH. The visceral fat is an active endocrine organ making a whole lot of inflammatory markers and adipokines, which also directly has an effect on the GnRH, LH, FSH axis. The visceral fat produces leptin. Increase in leptin has an effect on the testes in terms of decreased testosterone production. And then insulin resistance decreases sex hormone binding globulin, also has an effect on low testosterone, and that in itself causes a low testosterone production. And so you can see that central obesity, mainly visceral fat, has a profound effect on the entire endocrinopathy around testosterone, its aromatization, and its production. So whilst our clients will only have this on their minds in terms of testosterone, you and I need to realize that testosterone goes beyond sexuality. And here, very early on, I mean, this is in 2006, so over 15 years ago, a big study, and after that, there were multiple other studies showing the same. If you look at testosterone levels and mortality, in blue are men with higher testosterone levels. Their survival was higher than men in red here, and then the men in green are the ones that had lower testosterone, and you can see the cumulative survival is much less. So let's just take a point in time. Let's look at this line over here. You can see that there's a massive difference in terms of survival between these two groups over a short period of time. But like I said, this study was then repeated. This was an interesting study because it was a veteran study, but this one I find even more interesting. So they looked at all-cause mortality just looking at testosterone levels. But here, the reason why it was an interesting study is that they looked at just all men with normal testosterone. And they adjusted it for age, BMI, waist, hip circumference, smoking, alcohol use, and exercise. And I'm just going to draw something over here. We all know that everybody falls in under what we call a bell-shaped curve, right? So what they looked at is the entire bell-shaped curve is representing normal testosterone levels, 12 to 27. And what they found was that men who are sitting with levels around 18, around, let's say, 12 and 15, have a higher all-cause mortality than men that were sitting around, let's say, between 25 and 27. And it was true right along the curve. So even though they've adjusted for some of the common risk factors that we know of in this big group of men, there was definitely a level associated with mortality. This is another interesting study showing, looking at men with high testosterone versus low testosterone. Men with low testosterone seem to have more hypertension, around 40% more diabetes, around 37% more diabetes, cardiovascular death, 35% more, and 30% more risk of having metabolic syndrome. So can you see this goes beyond sexuality? So let's look at the biochemical assessment. So there's no lower limit. I mean, that level can go up to 2 in men. So ideally, you want total testosterone levels to be above 12. And if it's above 12, you don't really require treatment. Below 8, you definitely require treatment. And they say between 8 and 12, if the client is symptomatic, you will give them a trial of treatment, and if the treatment improves the symptom, you carry on. And so that's the 8 to 12 with symptoms that need to be given trial of treatment, provided you've excluded some of the causes. So I've mentioned underactive thyroid, hypothyroidism, high prolactin levels, hemochromatosis, high ferritin levels. Those are common treatable causes. Now, how are we going to approach treatment? This is vitally, vitally important. I cannot emphasize the importance of this. So as soon as you've established that the testosterone is low, you need to ask the patient, is fertility important or not? Because most men are only thinking about testosterone in relation to their sexual lives. You need to dig a bit deeper and say, listen, guy, are you still planning to have children? Are you done with the family or not? Don't make assumptions based on whatever you're doing in your life. You haven't had a kid at 82. So here, if fertility is important, you cannot give testosterone. Now, to some of you, that will sound obvious. I can tell you, about a decade ago, I had a client who came to me for infertility. And what do you think one of the doctors at one of the top infertility clinics in Johannesburg gave him? Because his testosterone was low, was told, take some testosterone, was given libido. This is an infertility clinic, one of the top institutions at the time. I mean, there's many more now. Actually gave a male patient libido in a hope to restore his fertility, and downright made sure he was never going to get a kid again, because libido is going to act as a contraceptive. So what's the contraceptive in a female? When a 19-year-old goes on a contraceptive pill, what's in it? It's a hormone. Majority of the time it's estrogen. Sometimes it can be progesterone, but if you give a hormone in high enough doses, it will down-regulate that axis. That's exactly what this high estrogen in this male is doing. It's down-regulating all the sex steroids. You see, GnRH is sensitive to estrogen and testosterone. It cannot differentiate between the two. So when it sees too much of the one hormone, it will down-regulate, because LH and FSH are the same in males and females. In males and females, they're both responsible for fertility and hormone production. In females, it's estrogen. In males, it's testosterone. So here, you need to make sure, and if fertility is required, your treatment needs to be based in terms of restoring LH and FSH. So you got to use agonists. This is not the talk for that. A talk on fertility, either for females or males, is a talk on its own. So here, once the person says, listen, I'm done with the family, I don't really need a family, then you will replace the testosterone. So how do we treat? Well, we're aiming to achieve testosterone levels in the mid to normal range. And you can use any approved formulation and choose it based, or not on your favorite one. What does the patient like? So the patient only knows what he likes if they know what's available. So you're going to have to give them all the options. Consider the pharmacokinetics in this client. We'll touch on that. Treatment burden and cost. So what's available there? This is by no means a full diagram. So there's libido, it's an injectable. There's testosterone injectable. There's Sustanon, that's an injectable. There are pellets, and then there are bioidentical testosterone creams or gels available. So world over, I'll start on this side. You can get little tablets or capsules or troches that you can put in your mouth, keep it under your tongue, and it will slowly dissolve. There are buccal gels that you can put on the inside of your mouth. There are pellets that you can keep just under your incisors, one on either side in the morning, and it will slowly dissolve. There are transdermal gels and patches. Patches are not available in South Africa, but the gels are. You get subcut pellets, and then you get the injectables. And you get the weekly injection, you get the 3-weekly injection, you get the 12-weekly injection in South Africa. The same 12-weekly injection in South Africa, which is Nebido, it's a formal injection that is available in a 3 ml injection in the US as an 8-weekly injection. We're going to touch on these. What's important is to understand the pharmacokinetics. So in South Africa, all 3 of the injections that are available in South Africa are the same testosterone. They are bound to different oils, and they have different molecules on their structure, and that's going to determine the half-life. So are there some clinics here in the northern suburbs that tout that theirs is a personalized testosterone that is specially made for that client, and then they'll give them like 0.7 of a ml or 0.4 of a ml and make them come on a weekly basis or a 4-weekly basis or a 2.5 weekly basis, trying to make them believe that they've got a special testosterone just for the client, and basically it's all a hoax. Because these formulations have been around for a long time, and basically their pharmacokinetics is well known. So the weekly injection, well, you'll notice will have a bigger peak. The 2-weekly injections will have a peak and a trough level, but most of it will sit within the white, which is the normal reference range. The 3-weekly one, which is not available in South Africa, has a better profile, but sometimes you're going to have it go too low in your trough levels. And then you've got the 12-weekly injections, which has a peak and then lasts for a long period of time. So you get different injections in the market. Sorry, that was a 3-weekly injection, 4-weekly injection. And then this one, in South Africa, you've got the long-acting one, which you have a peak for the first week, and then you're going to get nice steady state levels that will last for 12 weeks. So how do we use it? What do we use? So depot testosterone, you can use 100 milligrams once a week. You can give it intramuscularly. The client can inject it themselves in the thigh or in the arm. And basically, after about the 3rd or 4th injection, you want to get a trough level. So you want to get the worst level. That means if your client has been told to inject every Monday, you want the next test, once you've got a nice steady state level between the 3rd and 4th week, the day before they're going to go for the next jab, which is a Monday, on a Sunday, you want to do a blood test. So if it's a weekly injection, you want to do your test just before you know it's going to get finished. There's no point in doing it in day 1 and 2 and 3. You know it works. So you want to see whether the interval in this client is actually a week. Because in some people, for quite a few different reasons, you may need to bring a weekly injection to every 5 days or a 7-day injection to every 10 days because of aromatization, because of metabolism, because of whatever in that client. So you want to dose titrate it, and we're going to go through how that is done. Then you get Sustanon, small vial. The client can inject themselves again in the thigh, in the arms. It can also be injected by a doctor in the buttock. And basically, you've got a bit of propionate, and then you've got a slightly longer acting one, and basically it's mixed. And this one can be given every 3 weeks. Again, once you've given about the 3rd or 4th 3-weekly injection, you want a trough level so that you can dose titrate it to the client. Then you've got libido, which is a formal injection. It must always be injected in the buttock. You have to go slowly. A doctor and a nurse can do this. The client can't do it themselves because it's a 2-minute injection. Now, this one's very important because if you rush the injection, what's going to happen is you're not going to have a nice 3D spherical globule of oil that is suspending testosterone in it. So you're going to have a rupturing of the tissue. And remember, the absorption was calculated according to the surface area of that bubble. So you have to go slowly. The other reason why you don't go fast is that if you happen to be close to a vessel, so of course, good injection technique, you go in, you withdraw, but you want to make sure there's no blood, and then you go in slowly. And now if you just rush the stuff and you rupture that parts of that tissue in that area, you're going to start forcing some testosterone into the vasculature, and that can end up causing little fat emboli in the lung. They're not going to die, but they're going to sit there hacking for the next half an hour in your practice, and then it's going to resolve. So you want to go slowly. There are some people in, I've had some clients coming from Pretoria, but it's not restricted to Pretoria, where because the formal injection is painful, whether it was the client's idea or the doctor's idea, they said, we just split it 2 mils in each buttock so it's less painful. Guys, go back to your physics. A 2 mil bubble is going to have a different surface area, even if you multiply it by 2, than a 4 mil bubble. So your 2 mil bubbles in each buttock is now not going to last 12 weeks. And so that's a very quick way of wasting money because there's an expensive one. So don't play around with the physiology. Don't get clever with these things. These things have been tried and tested. So once you've got a client with a low testosterone, with this particular one, you give an injection, then you do a booster at 6 weeks, and then every 3 months. Again, after the 3rd injection, you will do a trough level. You want your worst level. In terms of transdermal creams and gels, so you got a gel in South Africa marketed by a pharmaceutical company, Androgel, it's 1%. It comes in a sachet like this. You tear it and then you apply it on your arms, or your thighs, preferably where there isn't too much hair, and obviously your ankle. And then we got the compounding pharmacies who can make it in a 2.5%, a 5%, 7.5%, 10%, 12.5%, and a 15%. So it allows dose titration. Typically, it comes in a pump. So Fagron has a very nice pump. 2 clicks and you get a mil, and you apply it again to your arms and thighs after a shower, and it will work. Here, once you're on a transdermal, about a month later, do a blood test. Now, why are we doing blood tests? Because you need to make sure that you're getting to where you want to be. So monitoring becomes important. So first thing you want to know, did the symptoms improve? Because that's originally why you used it, right? So did the treatment target the symptoms? Does the patient have any side effects to the treatment you've chosen? And then you want to be restoring testosterone levels to mid to normal reference ranges. And then you dose titrating. And so here, that's important. So my trough levels in all my patients should never go below 15. So if normal's 12 to 27, just before the next injection, they shouldn't have a level below 15. If they do, then I need to work out why, and we're going to touch on that. So you got a client, you've given testosterone to, you've worked out the baseline. So you got a client with a testosterone of 10. That's a sex hormone binding globulin. It's not a pituitary problem. The person is diabetic. PSA of 1.4. So when you go through that algorithm, you'll see it's always important to have a baseline hemoglobin and PSA, because I'm going to touch on it. Hematocrit and hemoglobin is one of the side effects of testosterone therapy. It can go up, and you want to make sure that there's no prolactin issue as a cause, and there's no thyroid as a cause. So you've excluded thyroid, there's no prolactin issues, sitting with a nice PSA, patient's diabetic, hopefully well controlled, pituitary is not a problem, you're sitting with a level of 10. This person does not want any children now, so what do? So you give testosterone. And on your trough level, you end up with levels of 6. So that means here the client needs to decrease the interval of whatever they were using. So if you're using depot testosterone, 1 ml per week, you will now say 1 ml every 5 days. Again, after 3 or 4, you don't have to bring the client in, just do a blood test, total testosterone, have a look. If it's above 15, that's the regimen they're going to follow. If they did Testosterone and the levels are 6, you'll say, right, you can't use it every 3 weeks. Instead of every 21 days, you might need to use it every 15 days or every 2 weeks. Get your trough level. If it's good, it's fine. Your libido, after the 3rd libido injection, you look at the levels and the levels are 6. That means this thing is not working for 12 weeks. Try every 11 or 10 weeks. So like anything else in endocrinology, you've got to personalize the treatment and make dose adjustments. What happens if your levels are sitting at 30? That means this thing is lasting longer than we expected. So then increase. Your 1 weekly injection may go to 10 days. Your sustenance may go to 4 weeks. Your 12 weekly injection may go to 14 weeks. Or if it's the cream, it's easy. Move from 10%, if that's what you started, to 7.5%. Of course, the androgel is a bit more difficult to manage. And why is it important to adjust a level that is 30 just before your next injection? Because you're going to have an increase in aromatization. Your testosterone is going to be shunted to estradiol, and that varies from client to client. So high estradiol levels will cause an increase in body percentage fat. It works. It affects basically cholesterol in a negative direction. High estradiol levels is going to make the guy a bit more emotional. And a high estradiol level is going to cause stonies, gynecomastia. And so here, that's why you don't want too high levels. Now, you can get aromatization of testosterone at normal physiological levels. Then you need to block this. And so you can either use Leone's estrogen balance. It is a natural product that has 7 different items. It has very high doses of the sulforans. The sulforans will decrease estradiol production. It will also decrease estradiol to estrone conversion. It has I3C. It has DIM. It has calcium deglutarate. And these will all decrease estradiol level. Typically, you can use 1 to 2 estrogen balance tablets a day. Or you can use an aromatase inhibitor. And one mustn't forget that this is what the client wants to do. You don't get tempted to do this for the client. That is why 30 can be a problem. The client will be very happy. They think, listen, you're the next best thing after chocolate ice cream. But what's important is the long-term effects of this guy. Now, in some of your clients where you were not expecting the testosterone to go below 15, before you dose adjust, I would advise you to look at the estradiol levels, because if the estradiol is high, that means the testosterone is being converted. That's why you're not achieving good targets. So it might be prudent to just try and block the estradiol effect. And I aim for levels of around 40 to 70 on the reference range here. Don't forget the goal. This is what the guy wants. This is what you want. You want to restore metabolic parameters. You want to increase muscle mass, strength, and function. It will have an improvement in bone density because testosterone will convert to estrogen. The lower the testosterone, the less the estrogen, unless the testosterone was low because of aromatization. It has an effect on cognitive function, improves psychosexual function, and has been shown to increase quality of life as well. So what can physiological replacement achieve for you? So this, I mean, there's a lot more studies that have come out, but I want to show you how far back. This is old data. Already in 2006, you took a patient with type 2 diabetes with insulin resistant, gave them 3 months of testosterone treatment, and what happens? The HOMA index improves. The HbA1c comes down. Within 3 months, fasting glucose comes down. Waist circumference comes down. Total cholesterol comes down. So here, Paresh Dendona, that same guy who looked at his diabetic patients and said, listen, they're testosterone deficient. So he said, let's give them something, let's see what happens. And there was an improvement. That was a short study. What happens to fat mass? So this is a much longer study. Already by 2012, it was a 15-year study. This has continued to go on. And here, mean age of 42, over 300 men, using over 6,500 injections over a 15-year period. Average waist circumference at the beginning of the study was 103, with absolutely no other change in their other treatment. Look what happens. The weight comes down from 103 to a massive, almost 25 kilogram weight reduction over a 5-year period. So that's what testosterone can do. Another study, diabetics. This was even before the SGLT2s and the GLPs came on the market. We knew those days we used to struggle with patients with type 2 diabetes because all the treatments we used for them would make them put on weight. Remember, this was before the SGLT2s and GLPs came out. So those were the days of the SUs and insulin. And so here, patients with type 2 diabetes, testosterone and lifestyle, and what happens? So just lifestyle does work, brought the waist circumference down. Lifestyle and testosterone brings it down even more, double the amount of loss of waist circumference. What about lipids? 15-year study, because there are people who tell you that testosterone will cause lipid profile to become abnormal. Well, over 300 men followed for over 15 years. Like I said, the study goes on longer. In the majority of them, total cholesterol comes down. Triglycerides comes down. Bad LDL goes down. And HDL goes up. Remember, most of the physicians that have told you in the past that testosterone causes lipid profiles to go abnormal come from looking at people that have abused testosterone. There's a difference between the abuse of testosterone, anabolics in the gym at high doses, as opposed to physiological replacement. You must distinguish between that. What happens? You see, we know in patients with type 2 diabetes, HDL typically low, patients with metabolic syndrome, HDL typically low. So lifestyle changes, we know marathon running can double HDL. So here, activity increase HDL. Those same clients, but you add testosterone and the HDL, the good cholesterol, goes even higher. What about triglycerides? Exercise brings it down. What about exercise and testosterone in testosterone deficient men? Comes down even lower. What about blood pressure? Same 15-year study. I told you now it's over 25 years. 300 men. Follow them on. Don't change their blood pressure medication. Systolic reductions over a 5-year period of over 20 millimeters mercury. That's exactly like what your antihypertensives will do. And in terms of diastolic reduction, better than actually every single agent hypertensive product on the market. This is changing no other medication in these clients. So this is another study, 255 men over 5 years, middle-aged men, systolic, diastolic coming down. Look at the p-values in these things, guys. What about insulin resistance? This is the Diamylite study, small study. This bigger study since then, but this was, remember, the early ages of testosterone replacement where people were even scared to give testosterone. So the early studies don't require big numbers. So diabetic men, and you look at diet and exercise and what happens? Well, HbA1c comes down. We know diet and exercise helps HbA1c. Well, if you do diet, exercise, and testosterone, the HbA1c drops even more. By how much? Over 1.2%. Remember, to register a drug for diabetes, you need to demonstrate that the HbA1c drops by 0.7%. Here's HbA1c looking in another way. Average HbA1c in the beginning of the study in these 255 men, 7. 5 years down the line, around 6. 1% reduction, not changing the antihypertensive treatment. Same story here. So what about some of the controversies in testosterone? Well, let's look at PSA. So if you just look at any person age 20 and follow them over 80, and you'll say, but who did this? These are veteran studies. So there's quite a few armies in the world where you start your army career at age 18, and you've seen it in the movies where basically they have a full physical with a finger up every orifice. And of course, they're trying to make a joke out of it, but they go through extensive blood tests as well. And that forms the basis of a lot of these studies, and then you follow them on. And so if you look at prostatic volume in normal men, the natural progression is for prostatic volume to go up. That's why most men by the age of 85 will have benign prostatic hypertrophy. What happens in men with low testosterone? Well, their trajectory is lower. So when you give them testosterone, all they've done is they've caught up to the men that were having normal testosterone projections. The worrying thing is that once you have a doubling time in PSA, once you have a doubling in PSA over a short period of time, so your baseline was 1.2 and you started testosterone treatment, and a year down the line it's 2.4, it's still below 4, but this should alert you to the fact that the patient might be harboring an early prostate cancer and you just fed it. You didn't cause it, you just fed it. And so from that perspective, you've done this client a favor, because even before any finger can feel it, you send them off to a urologist. The urologist is going to do basically a sonar. They will do biopsies, and they will then probably, if it is malignant, pick it up in such an early stage that it's 100% curable. Whereas in the old days, we were relying on the finger, and it would have to be quite big before we can feel it, whether the patient has got testosterone or not. So here, testosterone can't cause prostate cancer, guys. Then the peak in prostate cancer will be at age 18, not 70 and 80. But once you got it, yeah, certainly it will feed it. So where's the data on this? If you look at cancer rate in testosterone therapy trials, up to 3 years, 1% of clients that were on testosterone had prostate cancer, and this was no different to the placebo group or the general screening data rate, which is around 1%. So I'm going to end again just to remind you that all men will have testosterone loss. And this is why it's so beautiful to be in South Africa, because somebody obviously thought about this. So if you between the ages of 20 and 30, go for mere lust. If you between 36 and 50, you need the Canon cop. Get to the retirement age, rust and vrede, and here you've lost everything. So the choice of the wine you make probably determines what's happening with your testosterone. So this is a nice chart. You can just Google it. It's Family Medicine Center, not South African, but basically summarizing what I'm telling you. So testosterone is a male hormone. It's very important for libido, energy, erectile function, immune function, bone and muscle development. It has many effects, from cognitive function to sense of well-being to energy, heart function, body percentage fat, and libido. It has an influence on blood pressure, cholesterol, type 2 diabetes, bone density, and heart, and of course, red blood cell production. So when you give somebody testosterone and you look at the hemoglobin and it's going up, don't stop it. The patient just needs to go for annual or biannual venesection. Remember, even at the turn of the 18th to 19th century, testosterone was used in females as a treatment for anemia. So we've always known that it causes hemoglobin to go up. Don't forget the symptoms of testosterone deficiency and measure it twice. If it's low, you've done it properly, offer the patient treatment based on funds, how easy they're going to manage to do this, because there's no point in giving a male a weekly testosterone injection when they're traveling a lot and they're flying around, because then they're going to worry about refrigeration and whether it's going to be confiscated. So tailor make the creams or the gels or the injectables to the patient's pocket, but lifestyle as well. So it's time for question and answers. And while you guys are gathering your thoughts, I'm going to go through. You can see this was dated just recently. A colleague of ours sent a case through, and this is a middle-aged male patient, infertile, but no desire to have children, normal sexual development, has a history of hypercholesterolemia, is not diabetic, has difficulty in losing weight despite adequate diet and exercise, no impotence, but have a low libido. That means you can get erections, but the libido, the lust for it is low. This is a urologist, so the urology examination was normal, except that there was hypertrophic testicles. Remember, testosterone has a stimulatory function in terms of testicular size and penile size. So if your testosterone was 20 and now it's dropped to 10, yes, you are going to have smaller testes. Yes, your penis is probably going to shrink a bit. However, if your penile size has been whatever it is as an adult, taking more testosterone is not going to make it grow back. It just takes it back to where it was. So a normal size that has decreased is a sign of testosterone issues rather than the other way around. And this client, the cortisol was 540, which obviously it was, I am not privy to how it was taken. It was done at Bera 2022, hopefully in the morning. And so early morning cortisol, this is a bit on the high side. Testosterone was 12.8, normal's 12 to 27. Sex hormone binding globulin was 33. Here, the free calculated testosterone index was low. And so they looked, FSH and LH was not low. So that means this was not hypothalamic or pituitary nature. And the prolactin was 20 and it was repeated, it was 9.2. The doctor doesn't say what was done. assuming nothing was done. A year later, the bloods were done, cortisols were better, testosterone was higher. Now, a high cortisol is like high cortisone. Remember, I told you one of the drugs that can drop testosterone is cortisone. So whether you're taking cortisone from the outside or you're making too much of your own cortisol, same shit. It's going to suppress it excess. So here, presumably, the cortisol had an effect on that testosterone level. But the question here was, would this patient benefit from TRT? And if so, what regimen? So here, I would have done a few more tests, right? So prolactin is not a cause. I want to make sure thyroid is not a problem. And I would like a DHEA as well, because when the libido is low, remember, libido is the list for it. It could be low testosterone. It could be a high estradiol level. It could be low DHEA level. It could be high cortisol level. Out there 10,000 years ago, when you are hunter and gatherer, you're not going to happily frolic away there in the fields when there's a lion 100 meters away. That was your danger. That's your flight and fight hormone, your cortisol. So, of course, you're going to have a low libido. So, when I get a client with low libido, the first thing I want to make sure is that the DHEA is good, that the testosterone levels are good. These are the two androgens. Too much of one and too little of the other doesn't compensate for each other. What happens in some of my clients is that I notice that the testosterone is not bad, low end of normal, but their estradiol levels are up. High estrogen is obviously going to affect the libido in men and performance. So then you want to try and block that aromatization. So here I would have checked the estradiol level, checked the thyroid. Now let's assume, for the sake of this case, it was fine. Would I have treated this client? Let's assume the cortisol was fine, because here cortisol can affect all of this. Difficulty in losing weight, libido issues. And so here, if this was fine, I would have repeated it. And if it's still low, I would have said, on the low end of normal, I would have said, well, let's give you a trial of treatment and see what happens. So here they waited and the testosterone was fine and the cortisol normalized. So for me, I take each case on its own merit, but I can tell you I would have been swayed here. I can guarantee you that the conversion of testosterone to estradiol was probably higher in the face of that being high, and the fact that the libido was low as well. So here, let's put another case study. This was a client I just saw on Monday. I did ask him for permission. So thyroid's fine. Leonie just sent the slide through about 20 minutes ago. And, just before I came in, I don't know if those of you came online saw me leave this desk twice, because I walked out there and I told my son, I said, listen, I'm having a problem with this laser pointer. And my wife just started laughing because she said, your 10-year-old just said, watch, Dad's going to come out 5 minutes before the talk, begging somebody for help because he just never seems to get this thing right. Anyway, so I'm also a last-minute slide collector. So he's a 51-year-old male patient, has got a boob, thyroid's fine, had a bit of a fatty liver. The rest of the indices were all good, no prolactin issues, not on any antidepressants, comes to me with a testosterone level at age 51 of 8. Now the GP had sent him to me, so we've got a before one as well. And so here, I know all of you are going to say, well, that 70 doesn't seem to be too bad. But for me, having a level of 8 coming off a low base, that 70 is quite high, because had that been then higher, at 15, this would have been higher. So for me, the temptation is always to say, well, if you can get your own circadian rhythm right, do that first. So I would first attempt to block this using estrogen balance. And if it goes down and this guy goes up, we know he's making enough. He's just aromatizing it to estrogen. However, at some point, even if that works, all males will start dropping it. And then when it does drop, you give them testosterone. And again, I give them the options and I tell them, listen, are you the kind of guy who uses a cream or not? Not. Then don't give a cream because they're not going to use the cream. And if you don't use it, it's not going to work. Then you go into the testosterone. But some men are scared of testosterone, of injections. So then you can't use injections and you have to use creams. So from an injectable perspective, you give the person all the variables, the pharmacokinetics in terms of the weekly, the 3-weekly or the 3-monthly, and it's about convenience and cost and watching what happens from an aromatization perspective. And so it's actually a very rewarding condition to treat. So I had recently given this talk to the Homeopath Society, and they obviously preempted some of the questions that they wanted to ask. So they had posted it. So Leonie just typed it all out. And this is the direct email that came from Dr. Joanne Pouts. And so I think I've answered some of them, but let's just go through it. What are the ideal testosterone levels according to functional medicine standards? So in men, it's still 12 to 27. Whether you're doing functional medicine or not, it's the same here, right? Whilst testosterone has anti-aging benefits, if used responsibly, it's about getting to good levels and making sure it doesn't aromatize. So I think I've addressed that. What are the adverse effects of testosterone injection? So number 1, pain on site. Number 2, if you've bloody left bubbles in there, there's going to be a bit of a problem. Number 3, if the formal injection is not injected slowly over a 2-minute period, you can basically have micropulmonary fat emboli. The person's not going to die. They have to sit in your room. They're going to hack away, cough a lot, and then it will normalize. If you've got a SATS meter, put the SATS meter on and just make sure everything is fine and wait it out. But I've never seen that in my 30 years of using testosterone injections, but it has been reported. In terms of other ill effects, so adverse effects, it will cause aromatization in some male patients. And so you need to block that estrogen. Watch the hematocrit, because of course, if the hematocrit goes high, the viscosity goes up. So there the patient will need to venosect. I keep the hemoglobin levels below 17. Anything above 17, I want to venosect. And you can even watch the hematocrit. And when you venosect, you want the hematocrit down to 0.48. You want to keep an eye on the PSA, make sure it's fine. So over the last 30 years, have I had men with testosterone use and prostate cancer? Yes. And they've all been picked up early because the levels doubled from 0.7 to 1.4 over a short period of time, or from 1 to 2, or from 2 to 4. Send them to the urologist. The urologist picks it up very early because, remember, it didn't cause it, it just fed it. So here, if you're waiting for it to grow big enough for your finger to feel, then it's too late. So here you're actually doing them a favor because you're picking it up early. So aromatization in man boobs, yes. Any other factors leading to testosterone aromatization? So when do you see an increase in aromatization in men? So one of the first clues for me is I tell them, when you were a teenager, did you have stonies? Did your friends pinch you because they thought they'll play a funny game because it hurt you? So if a young guy got stonies when they're young, they're going to get it when they're older. Why? Because during puberty, you just had a peak and you aromatized. And then hopefully you normalize. But later in your life, same shit's going to happen. And so where do I see an increase in aromatization? So as men get older and you develop a boob, so when you got increased visceral fat, there will be aromatization. I also see it with fatty liver. And I also see it with poor gut microbiome, dysbiosis. I'll give you a classic example. So there's this very good sports GP in Pretoria. She runs basically a sporting practice, and so she gets all these sportsmen. And so years ago, she asked me, I think over WhatsApp or email or whatever, to say, I'm having a problem with this cyclist whose testosterone levels are good, but the estradiol levels are through the roof, through the roof. It was over 2,500. And I said, okay, very clever. I said, I just use anastrozole, it will block it. Anyway, lots of anastrozole, nothing doing. Didn't work at all. Brought it down, but I mean 2,500. Anyway, she sent the client to me. This client still comes and sees me. They moved to the UK, but they come once, twice a year. And still a cyclist, doing fine. And this was my first foray. I mean, I've been working on the gut microbiome for years and years and years and years. But this was my first classic example where the gut microbiome was totally responsible for that high estradiol level. Because what I then did is, when they came to my practice, I took my own history, realized that this guy had like a very strong history of GIT issues and had dysbiosis. So anyway, after some tests, we established that there was dysbiosis, and I started working on the gut microbiome. We left him on maximum doses of an aromatase inhibitor, 1 milligram every day. That's a high dose. And we were still not getting anywhere. And just by working on the gut microbiome, that estradiol levels crashed. That, for me, was the first time I realized the importance of gut microbiome and aromatization. The literature still doesn't talk about it, but since then I've had many patients, so I'm just mentioning it here. So common cause, if you're a teenager and you had stonies, yeah, you're at risk. Second commonest cause, you've got visceral fat, definitely. Fatty liver, and then gut microbiome. Would you ever give testosterone injection to men? Of course, I give tons of it. How do you treat low testosterone? We've done that. What is the long-term impacts of anabolic steroids in young men using it for bodybuilding? So I get lots and lots of these patients. I actually like these clients because they're very interesting to manage. And so what do I see? I see lots of different things based on what they use. The ones that are using the conventional anabolics, the ones I've just mentioned, these are all anabolics, libido, depo, or sustanon. It's basically aromatization issues, balding issues, and hemoglobin going up, and basically PSA issues. And it can all be managed. However, with some of the other interesting anabolics, I see liver damage, I see kidney damage, I see adrenal issues. And so it varies from person to person. And so I've had lots of clients using the same stuff, and there's some people whose body is so forgiving, the liver, absolutely nothing wrong, and others just use it for 2 months and their livers are buggered. So it's a very individual response. And so the long and short of it is, if a young person's taking anabolics, they're risking their fertility. So I always tell them, listen, go and store some sperm or use a PCT. So make sure that while you're using your testosterone, make sure that your pituitary axis is still working by using the stuff that we use for fertility. That, I said, is a talk completely on its own. And obviously you try and discourage them to use it. What would make you check estradiol level in men? Listen, I'm an endo, I tested in on men. What are the normal levels? It's a large reference range. You can see I typically aim for levels between 40 and 70. At what point would you give a man a whole again estrogen balance? Whole again is a natural range that is gluten-free, wheat-free, dairy-free, colorin-free, preservative-free. It's got many products, one of which is estrogen balance, and it's got quite a few agents that I mentioned earlier that basically balances estrogen and progesterone in females and estrogen testosterone in males. So I use it when the estradiol levels are higher than 70. When do you use testosterone cream in women? No, that's another talk, guys. So we leave women out for now. How do you change DHA levels without using DHA? Listen, practically impossible. Why did they ask us questions? Because remember, homeopaths, unfortunately, and it's unfair, are not allowed to use this natural occurring hormone just because it was scheduled as Schedule 5. So I think it's completely unfair, but anyway, who am I to say? So obviously for them, it's very difficult to get the DHA levels up. When it's not too low, ashwagandha can help a little bit, but listen, the kind of clients that come to me have very low levels, and then I have to give DHA and pregnenolone and or. And then I guess for the homeopaths, it's important just to focus on cortisol, because if the cortisol is high and you try and bring it down with an adaptogen, you'll be able to recover some of that DHEA. All right, so this is their question. Now, Leonie's put out this news flash for those of you who use whole again products or stock it. She's extending the discount to the 31st of October if you order, and for every 10 you get one free of all her products, but estrogen balance for every 12 you get one, and it must be put in as a single order. So this is her contact details. As usual, we put it up, and now I think I'm going to stop sharing because I need to find the rest of the questions. So listen, guys, this is a nice summary slide of what testosterone can do. This is females. Okay. Like I said, I've got over 180 slides. So now I'm going to stop sharing, and we're going to take some of your questions. Anybody wants to kickstart? Hey, let's look at the questions. 74 people online. There must be questions. And let's see. Okay, Natalie is saying, if that 51-year-old patient presents with slightly raised early morning testosterone levels, is this concerning and should it be investigated? Raised? No. So, I mean, that's where the term Superman comes from, right? So normal's 12 to 27, and some men have levels of 35, 36. I've got some 80-year-olds not using anything. Bloody hell, and I don't have that level, I'll admit here in public, will have levels above 27. So normal supra high physiological levels in men are not an issue unless they're aromatizing. That's when it becomes an issue. Otherwise, no. And then, and I've had a lot of them. So have I ever seen, I'm just going to preempt a question. Have I ever seen men with naturally high testosterone levels have problems with hematocrit and hemoglobin? No. And in fact, there's work, part of that 187 slides is work done in Europe, already long-term work showing that that same veteran study where I said everybody falls in under this bell-shaped curve where 12 is here and 27 is here, and they followed these men up, and men with normal levels, but on the lower range of normal, when they followed up, they have a higher risk of prostate cancer, higher risk of all-cause mortality compared to the ones that are here. So no, I don't see any problems there. Now, guys, where's all the questions? There's over 70 of you guys. And you can put, yeah, go for it, Michaela. Put up you can unmute yourself and ask the question, please. Michaela, you've got your hand up, so you can go for it. Anybody else?
There's some more questions on the chat box.
Okay. So I'm missing the chat box. Let's go to it. So they're chatting amongst themselves. All right, no problem. Let's go. Oh, you're right. Okay, good. We like questions. Let's see if I can push this thing down. Right. This is all your stuff, Leonie. Here we go. Apologies, I trust it's improved now. Should testosterone and estradiol be tested in all patients with metabolic syndrome? Yes. Or only if there's symptoms of low testosterone? No. No. Because remember I showed you work where patients with low testosterone can cause the metabolic syndrome, and metabolic syndrome can cause low testosterone. So it's a vicious cycle. So typically, um, and listen, as an endocrinologist, I can get away with it with the medical aids. I don't know if all of you guys are going to be able to get away with it, but certainly I measure total testosterone. And in the metabolic syndrome, of course, because of the increased visceral fat, you're going to get conversion of testosterone to estradiol. So yeah, I think I would. And then, sorry, missed that, done that. Okay, do statins lower your testosterone levels? Yes, I have seen that, not consistently in all patients. So if you've got a before level that was good and you started a statin, I showed you that atorvastatin has been shown to affect sex hormone binding globulin in actually freeing up testosterone. But yes, I have had patients with low testosterone. I remember 15% of statin users will have side effects, typically mainly joint, muscle, cramps related. These would be the very rare ones. What would cause low free testosterone index in a woman if both testosterone and sex hormone binding globulins are normal? Remember, that's why I want to do the talk on females separately. This test that we use at the laboratory was designed for males. So it's not sensitive enough to pick up levels in the low range. And in females, you're dealing with 0.3 to 1.9, depending on which lab you're using. And some labs go from around 0.8 to 2.9. So it becomes a bit more difficult. And so the only thing, remember, it's a calculated index. So they take age into account, they take the sex hormone binding globulin account. So here it's quite easy. You can see that that sex hormone binding globulin is quite high. And that level is quite low, on the lower range of normal. So that's why the free testosterone index is gone down, because you're producing low amounts. Most of it is being bound, and so there's going to be very little left. So here you need to work out why is the sex hormone binding globulin high. And typically in females, it's because they either on a contraceptive pill, because that's giving them too much estrogen. So the body is trying to bind that extra estrogen by increasing the binding globulins, and invariably it's going to hold on to testosterone, cortisol, and thyroid as well. The other cause can be estrogen dominance in the 40s, and then postmenopausally, if you're giving too much estrogen, then you're the one who's causing the sex hormone binding globulin to go up. Which herbs and nutraceuticals can boost or lower testosterone levels? Listen, my 17-year-old, when he was 15, he said, Dad, can I take ashwagandha? Because I read it can push up testosterone levels. So, and he thought testosterone will make him grow taller. So from that perspective, ashwagandha, there are some herbs. Ashwagandha can increase testosterone levels. Are there herbs that can lower testosterone levels? Ooh, herbs, not that I know of, but I'm sure they are. I'm sure they are. This you got to ask the clever people, the homeopaths. I mean, they much more well versed on herbs. But why somebody would want to lower it, I'm not sure. I know how to lower androstenedione, and I know how to lower dihydrotestosterone using natural products. So we do this for prostate health, for BPH. So nettle root extract, not nettle leaf, but the roots have an extract that will drop androstenedione and dihydrotestosterone. Pinjum does it as well. Lycopene, an extract from tomato, does that as well. Neem, an Indian herb, does that as well. Beta-cytosterol, another name called Sanoa from South America, will drop that as well. I know about 4 or 5 others, but generally, yeah, anything that drops those androgens, I know because we use it for preventing hair loss or hirsutism in females or acne that is driven by androstenedione down. But no, not to lower testosterone, huh? It's very weak. Which herb? Okay, I got that. Should testosterone and estradiol be tested in all? Okay, no, I think I've answered that one. Yeah. What is the effect of Ozempic and testosterone? Can they be used dual therapy? Yeah, 100%, Candice. So they completely do different therapies. Testosterone replacement in any form is to replace testosterone. Ozempic is for managing type 2 diabetes and in the future, it's going to go in for it's already in for registration and waiting for it. Ozempic can be used for fatty liver, and then of course Ozempic can be used for weight loss. And in America, they've launched a 2.4 milligram Ozempic or semaglutide called Vigomi. In South Africa, we've only got the lower dose, which is mainly being registered for type 2 diabetes. So it's being used off label because the other one is not yet available for weight management, but it's completely off label use. So yeah, they can be used together. So let's say you're sitting with a 55-year-old type 2 diabetic male. The diabetes is already going to cause his testosterone to go down. Let's say you've excluded thyroid, high prolactin, adrenal issues, and the testosterone is, let's say, 6. Yeah, you'll give testosterone. And you can also choose to manage his type 2 diabetes with Ozempic once he's been on 2 agents, and let's say the HbA1c is still above 7.5. Yeah, you can add it on as a third agent. So they don't contraindicate each other. And so that for me would be completely fine. Are the effects of aromatization reversible? Yeah, in some people. I mean, remember, it's a normal physiological process. You are meant to take some testosterone and convert it to estrogen because estrogen is important for fertility and for bone. Now, if you had no aromatization, there'll be osteopenia. And we see that in that interesting case where I told you where men are born with no aromatase activity. They just have testosterone, 0 estrogen, and yeah, their risk of osteoporosis and osteopenia is higher. So other effects reversible. So if it's physiological, no. Like that young boy who's got stonies. However, if the aromatization is there mainly from a gut microbiome problem or more typically with fatty liver or definitely with obesity, yeah, as the fat levels come down, you can improve that. Why don't we look at free testosterone? Isn't it a better indicator? 100%. But free testosterone is very expensive. You need to use an equilibrium dialysis mechanism to measure that. So it is shockingly expensive. Just so you guys know the cost of a total testosterone panel. So if you had to do total testosterone, sex hormone binding globulin, and a calculated free testosterone index, it's over 800. That equilibrium dialysis is very expensive. So yeah, that's ideal. How can you lower sex hormone binding globulin? Nettle root extract. Let's go. There's no modern medicine that can do that. Can you recommend a product combining those herbals that decrease DHA or androstenedione down? Yeah, so I've just, one product that has all, there's one in production from Hologen's perspective. So I don't know of any one product that has all of it. Years ago, I helped design the Solal one, and it had a few, but there is one coming. But I gave you a list of things already. Please feel free to contact Leonie. Okay, how do you prescribe and titrate aromatase inhibitors? Are there any long-term side effects? Okay, so Michaela, how do I use an aromatase inhibitor? The one I like is Arimidex or any of its generics. And I start off with 0.5 milligrams once or twice a week, and then I dose adjust it. Now, of course, I've done this forever. I'm not clever, so I've got background to say, right, I know when it's in this particular patient, I eyeball the amount of fat, I look at the estradiol level, I look at the fatty liver, I look at a few other things. And so in some men, I've had to use 1 milligram every day. And most I get away with half a tablet 2 to 3 times a week and no real side effects. I mean, remember, even in patients with breast cancer who use the stuff at extremely high doses, it may affect the liver. So I think the negative effects of estradiol definitely outweighs the small doses that you need to use of an aromatase inhibitor. If statins reduce testosterone levels, would Reddy's rise have similar effect? No, not potent enough to do that. Treating a male patient with low DHA and testosterone with DHA tablets, and it raises DHA to normal, but cortisol drops to below range. Do you manage this? Okay, I don't know if I'm getting this right, but let's just break it down. Treating a male patient with low testosterone, and I'm assuming low DHA, right? So I would give both. But have I had situations where I've just given patients testosterone and DHA, and the testosterone levels have improved? Yes, especially in the younger patients. Because if I give them, if the DHA is low and I give them DHA, invariably it helps the DHA cortisol ratio. And I told you a high cortisol itself can drop the testosterone. So from that perspective, I normally treat both because the ones who come to me, both are very low. But yeah, if like the testosterone was sitting at 12.4, 13, 14, you first treat the DHA and you see how it goes. And then it raises the DHA to normal, but the cortisol drops below range. How do you manage that? So if you can give as much DHA as you want to. It will never drop the cortisol low. It can only bring it into the physiological range. So if your DHA is high and the cortisol is still low, only 3 things can do that. 1, the patient's on cortisol. The ENT or the GP's been at them and given them some cortisol. And it can suppress it for anything up to 8 to 12 weeks thereafter. The second cause is that the DHA was low, so you treated it. Once it's high, it's not going to cause it to be low. So a low DHA can cause a low cortisol. And then in the third setting, I see it with gut microbiome issues. So here, a high DHA level never drops the cortisol too low. It will just keep it in mid-range. I hope that answers that. What range of free testosterone is optimal? So always remember, you're not getting a free testosterone by these labs. It's a calculated level. And then what range would I like? So it depends on the reference range your laboratory is quoting. So if you're getting a reference range between 30 and 90, again, you would go by symptoms. And I always like to keep mine on the mid to upper range of normal. But yeah, I think that's true for most hormones. So I've kept you guys here for an hour and 40 minutes. For those from VITS, I apologize. You guys are normally used to 40 minutes to an hour. We've been doing this once a month for, I think, about 12 months. And it's always advertised as a 1.5 to 2 hours so that it allows you guys to try and pose as many questions as you want to, so we're not rushed. And from that perspective, it also allows you guys to send in questions before time. So I hope this has been fine. Any last minute desires? So just so you guys know, for the new ones here, there's very few endocrinologists in South Africa, so we can't all cope with these kind of conditions. So that's why we'd like to train other physician specialists to try and manage these. If you don't try, you're not going to become confident. If you're not confident, you're not going to be using treatment. And so I'm a WhatsApp call away. You just WhatsApp me your cases. Keep it short. Don't give me like a whole long story. You guys are doctors. You guys are in the medical field. You guys are dietitians. You guys are psychologists, whoever. Keep it brief, just the vital, important aspects. And then I will just give you advice on WhatsApp. Or the best person is Leonie. Just email her the case or the Lancet or the empath results, and then I'm happy to just quickly write out a response, and then she normally emails it back to you.